This video discusses the first step in the Prem process in the outpatient department. It is well known that the commonest causes of child mortality is sepsis, diarrhea, and pneumonia. At the beginning of the illness, mothers bring children to the outpatient department with minor symptoms of fever, loose stools, or focus of infection. These may seem like trivial symptoms, but some can develop hypoxia or cardiovascular dysfunction and shock. It is important to differentiate between a child with normal physiological status and one who has developed organ dysfunction. One of Prem's innovative strategies to reduce child mortality is to pick up at-risk children in the outpatient department. Mom can help us. What additional question can aid in recognizing sepsis-induced organ dysfunction? But before we embark on the relevant questions, it is crucial to understand the difference between infection and sepsis. Infection is cough, cold, diarrhea and vomiting, impetigo, urinary tract infection, etc. Sepsis, on the other hand, is defined as a life-threatening organ dysfunction that is caused by infection-triggered dysregulated host response. Now let's go through the steps. The organism enters the bloodstream. The organisms activate the WBCs. In vulnerable children, the immune system mounts a massive cytokine storm, that is, a dysregulated host response. This massive surge of inflammatory mediators, which is supposed to destroy the organism, backfires. It also causes vasodilation and endothelial injury. The vasculature is a huge network and part of the cardiovascular system. Extensive vasodilation can cause pooling of blood in the peripheries with less blood reaching the heart, that is, loss of preload. Leaky capillaries in the systemic vasculature can also contribute to loss of fluids. Fluid loss exceeding 25% of effective circulating volume results in shock. The cytokine storm also impacts the cardiac pump. Decreased cardiac contractility leads to cardiogenic pulmonary edema. Cytokine-induced endothelial injury also affects the pulmonary vasculature. The latter causes pulmonary edema, which is also known as non-cardiogenic pulmonary edema or acute lung injury. So, signs of early organ dysfunction for a child presenting with infection is pulmonary edema, cardiogenic and non-cardiogenic pulmonary edema. So let's go back to the questions. Mom reports focus of infection and fever. What question can help us recognize shock? The first organ that is affected by shock is the brain. Cerebral hypoperfusion causes drop in the level of consciousness. So the first question for early shock is whether the child has also developed lethargy or incessant cry or not as usual or excessive sleepiness. The second question, does the child have respiratory distress? Now, respiratory distress due to pulmonary edema secondary to organ dysfunction should be differentiated from other more well-known causes of breathlessness such as asthma, pneumonia, bronchiolitis or congestive heart failure. The sequence of events will help us to recognize sepsis-induced pulmonary edema. First comes mom's history of fever and focus of infection. If she reports altered level of consciousness, and in such a child, she reports breathlessness, which is not episodic. We are ruling out asthma, or not since birth, we rule out congestive heart failure. Probably this child is having septic cardiogenic shock with pulmonary edema. A simple mnemonic to remember: F followed by A followed by B. That is, let's say, focus of infection, the child has dysentery. She has now developed altered level of consciousness, that is your triage question. Breathlessness, you infer hypovolemic shock. In this child with dysentery plus altered level of consciousness, ask for the second triage history of breathlessness. If she says yes, check out if the breathlessness was episodic, rule out asthma, or since birth, rule out cardiac failure. If mom denies episodic or not since birth, the likely possibility is pulmonary edema with gastrointestinal septic shock. Another example, in places endemic for dengue, fever plus altered level of consciousness is dengue shock. If mom reports breathlessness which is not episodic or since birth, consider the possibility of dengue shock with pulmonary capillary leak, pulmonary edema, or pleural effusion. A third example, mom reports cough, cold, fever, and breathlessness, which is first episode. It is possible that this could be pneumonia or bronchiolitis based on age. If such a child, mom reports drop in the level of consciousness, that is ALC, probably the child is hypoxic or shocked.
In summary, this video discusses the two major questions that we need to address mom who brings her child with minor symptoms such as fever, focus of infection, or loose stools. This has to be corroborated with the next following steps, that is, performing the rapid cardiopulmonary cerebral assessment, documenting your findings, interpreting the vital signs, and deriving the physiological status using the Prem triangle. Now, this process is not dependent on expensive investigations which are necessary which have been used in the ICU for recognizing sepsis-induced organ dysfunction. It is also an early pickup, not waiting for the child to become unresponsive with convulsions, with cold, clammy peripheries, prolonged CRT, and who is cyanosed or not breathing. These kind of children in the Indian context usually are rushed in rapidly into the emergency and will not be waiting in queue. So the Prem process helps in early recognition of organ dysfunction, helping using mom's intuition and our clinical skills in recognizing critical illness in the outpatient department setting.